So I think in the next 20 years, we're going to see a lot of this disease as the population ages and the prevalence of the many contributing diseases, particularly hypertension, diabetes, and obesity, rises. Um, so right now, as most of your viewers probably know, all of our trials of therapy for heart failure with preserved ejection fraction, or HFpEF, have been negative. Some of them were close, but not quite positive. But the Paragon trial was the closest, testing sacubitril valsartan, or Entresto, and showing that there was probably benefit in the Paragon population at for patients below the mean ejection fraction in that trial, which was 57%. Interestingly, the drug appeared more beneficial in women than in men, and at higher ejection fractions in women. So I think we still have more to learn about whether that therapy may actually have a role in treatment of this disease. Currently, the guidelines, both the US and the European guidelines, are very minimal. They say to use diuretics to control symptoms and to treat comorbid diseases according to guidelines, which in the US guidelines, that's specified more to be treatment of hypertension according to guidelines, because clearly blood pressure control to guidelines reduces the development of heart failure with preserved ejection fraction and probably improves symptoms in heart failure with preserved ejection fraction. So really the guidelines are super minimal: diurese and treat blood pressure, and then consider things like detection and treatment of coronary artery disease, which is often a contributor, and especially in the quite elderly, under-recognized. And then rate and rhythm control strategies in atrial fibrillation is appropriate, because atrial fibrillation is another common comorbidity. We're all eagerly awaiting trials of the SGLT2 inhibitor drugs in this disease to see if they have efficacy. And those trials, the big ones, should be announced hopefully later this year or early next year. So I sort of already talked about that in the last answer, but so we do not have any randomized controlled trials that enrolled only HFpEF patients with those comorbidities and looked at management. So basically we extrapolate from trials of those diseases where we should treat hypertension according to guidelines in patients with HFpEF. There is debate about what those guidelines should be. The SPRINT trial showed lower cardiovascular complications at quite aggressive blood pressure control to less than 120. But some people feel that in this population, such aggressive blood pressure control is not indicated, and there's still debate about that, and I don't think we know the answer. But certainly blood pressure control to less than 130 in diabetic patients and less than 140 in non-diabetic patients is warranted. And in select patients, even more aggressive blood pressure control may be helpful. Coronary artery disease, I think, is under-recognized in this population, and when it's systematically investigated, is present in a substantial portion of the patients, as many as 30 to 50% of them, depending on the geography of the population studied. But I think that aggressive search for coronary artery disease is warranted. I personally feel that non-invasive testing for ischemia is less helpful in this population, because often they have multivessel disease and balanced ischemia that's not as well detected by non-invasive testing, with the exception of coronary CT angiography, which I think is very useful in this population. It's a non-invasive test, and you can see whether there is, in fact, significant plaque burden and in how many vessels in the patient. So I'm finding personally that CT angiography is very helpful as a screening test to decide whether one should proceed to angiography in HFpEF patients. And then atrial fibrillation is a really complicated topic in HFpEF patients. Many of them have abnormal diastolic function. And when relaxation is quite slow, there may be a benefit to heart rate slowing in atrial fibrillation, and and the rapid rates associated with atrial fibrillation may be quite detrimental. But if diastolic function is severely abnormal and the ventricle is very stiff, often all of the filling of the ventricle will occur in early diastole, and in those patients, heart rate control is much less beneficial. And in fact, heart rate slowing can be dangerous because it can start to drop cardiac output in the patients. So a sophisticated examination of diastolic properties on echocardiography is often helpful in these patients. And then whether rate or rhythm control strategies are superior is not really well known. There are ongoing studies right now looking at this question. But I think that if a patient presents with decompensated heart failure, preserved ejection fraction, and atrial fibrillation, it is worth trying to restore sinus rhythm one time to see if that helps with the symptoms of heart failure. And if it does, then probably maintenance of sinus rhythm should be a goal in that particular patient. If you restore sinus rhythm and the symptoms don't really improve, then maybe rate control is all that's necessary in that patient. And in some of these patients, you just can't get them back in sinus rhythm, depending, until you treat the heart failure more aggressively sometimes. You know, the vast majority of patients with heart failure and preserved ejection fraction are quite elderly. It's most common in patients in their 70s, 80s, and 90s. We do see younger patients with HFpEF. And you know, even more than age, I think geography, particularly relevant to this conversation, geography plays a role, because in the United States, for example, this population is very obese. But in Asia, the HFpEF patients are much less obese. And so clearly the clinical phenotype in Asia is quite different than in Western Europe and the United States. So, you know, I don't think so much of it as an age thing, but in each individual patient, it's important to try to identify the contributing clinical syndromes, whether it's hypertension. It's in the United States, for example, African American patients get the disease at a much younger age, and it appears to be related, in part at least, to much earlier onset hypertension in that population, as well as diabetes and obesity. In elderly women, it's strongly associated with hypertension and less strongly associated with coronary disease, whereas in men, it's associated with coronary disease. And I think the Asian phenotype is still being worked out exactly, but hypertension is clearly playing a role, and coronary disease may play a bigger role in Asia, with higher rates of cigarette smoking and risk factors for coronary disease. Certainly in elderly men who present with HFpEF, it's very important to rule out amyloid heart disease, which has the wild type transthyretin amyloid has a 9-to-1 predilection men over women. And so in elderly men presenting with new HFpEF, it's really important to rule out amyloid. And probably in any patient presenting with unexplained HFpEF, screening for multiple myeloma and AL amyloid is very important, because you don't want to miss a treatable cancer that's causing the heart disease presentation. So, you know, the way I approach this disease when I meet a new patient is I try to think of the very broad differential diagnosis of HFpEF and start going through it and identifying both the important contributors that may be treatable, such as AL amyloid or transthyretin amyloid heart disease, you know, thyroid dysfunction, anemia, things like that. Renal dysfunction, very common contributor to this syndrome that may have a different treatment. And then when those things are ruled out and you have what appears to be an isolated disease that involves the cardiovascular system, looking at all of the comorbidities that are contributing and treating those as aggressively as possible. You know, so I think that that we still have some work to do to understand the role of sacubitril/valsartan in this disease. It looks like there is probably a benefit in some patients to reduce risk of hospitalization. There was clearly no mortality benefit to the drug in HFpEF. There's a lot of interest in seeing the results of the SGLT2 inhibitor trials in HFpEF, several of which are drawing to a close. We're hopeful within the next year we'll have some data about those drugs and their role in this disease. There's some device trials. There's a left atrial septal device that causes, produces an ASD that had early non-randomized, non-blinded open label studies in Europe that looked somewhat promising, and the pivotal trial has finished enrollment and is in follow-up. So we're waiting to hear the results of that as well in HFpEF. There's interest in a lot of other new therapies, but I don't think we have a lot of trials that are very close to completion. We have a lot of interesting trials just beginning. And so, I think over the next 5 years, hopefully we'll get smarter about phenotyping these patients and enrolling appropriate patients into trials. And there's lots of promising new therapies being tested. I've been in this field for a while now, and I'm a little bit jaded. I feel as if we've disproven a lot of really good theories about this disease, therapies that seemed logically and based on pathophysiology like they should work, that haven't worked. And it may be partly because we enroll very heterogeneous populations into our trials, and the therapies are only working in a subset of those patients. But it may be that we really don't understand the disease and characterize the disease sufficiently to do really effective therapeutic trials. I think we have a lot more to learn still. And while we're learning, we're all taking care of these patients. And it's, a real challenge.